Good morning or good afternoon, depending upon your location. How's everybody doing today? I'd like to welcome everyone to the Paragon Education seminar for October. My name's Andrew Bowman. I'm an acute care nurse practitioner coming to you live from central Indiana, where we're on Eastern Standard Time. If someone could just give me a heads up in the chat that you can hear me okay and I'm coming through okay for you today. Great, thank you. I appreciate it, everybody. So we're going to talk today on a topic that I really enjoy. I've given this talk a couple of times, and I've titled it Ruptured More Than Membranes, a case of aortic dissection in third trimester pregnancy. And this is actually a case that my partners and I took care of a couple of years ago. And like I said, I presented this case a couple of times. I am fairly new to the webinar business. I've given lots of live presentations, and I'm going to try and follow along in the chat as we are talking here today. And I'll try to pick up on the questions and answer them in real time. If not, if I don't get to your questions, if you'll scroll up to the top of the chat, I did leave my email address, and you can shoot me an email and I'll get back to you as quickly as possible. So let's get ahead and get started. And trying to get my slides to advance. All right. There we go. I apologize. I was told to use the arrows on my computer, not at the bottom of the screen. So I apologize for that faux pas. Hopefully the only one today. So getting on. So disclosures. I have one disclosure that I'm kind of proud to talk about because I was a consultant for Eli Lilly a couple years ago for their new product of nasal glucagon. Has nothing to do with this topic today, but they flew me to Germany, and as you can see from my photograph there, the Germans know how to put on a conference. They serve beer at their conference and wine, so if we could only do that here in America, that would be a great, great thing. So what are our learning outcomes today? Going to talk about the anatomy, physiology, and risk factors for thoracic aortic dissection. What would be the emergency department workup for this disease, the treatment for this disease, and to kind of bring this all together, a real case study of a young woman who experienced a thoracic aortic dissection. Little introduction of myself. I've been a paramedic since 1982, so I'm an old guy. I've been an ER nurse since 1991. I apologize, I still slip into the nomenclature of ER and not ED. I've been an emergency department nurse practitioner since 2007. I was inducted as a fellow in the Academy of Emergency Nursing in 2016, along with Cheryl Randolph, who is the owner of Paragon Education. I'm the state EMS commissioner for representing emergency nurses here in Indiana. I'm on several committees and represent ENA at the national level. I'm with AAENP, and I'm on the National Association of EMS Physicians EMS Advanced Practice Provider Task Force that was just created here in the last few weeks. So try to stay busy from both an advanced practice and a pre-hospital standpoint. So just some ground rules. Everyone's in a listen mode. If you can just type in a question to the chat box on the right. Again, I will try to keep up as questions pop up and try to answer them in real time. If I get behind and don't answer, just again, shoot me an email, and my email's at the top of the chat list. But again, andrewj.bowman@gmail.com. So we'll get started here. The slide I use a lot because I try to keep my slides less wordy. So anytime you see a busy slide, a kitten dies, just kidding, a kitten doesn't really die. I love cats. But I try to keep my slides a little bit more on the simplistic side, hopefully for y'all. So there is going to be a quiz at the end of this program. There are rules of aortic dissection. Rule number one, you are not going to diagnose every aortic dissection that comes through the doors. We miss things all the time in emergency medicine, and everybody here knows that. People come in, we miss MIs, we miss PEs, we miss appendicitis. We miss things. It is an art and a science in emergency medicine and in medicine in general. So rule number one is you're not going to diagnose every single one. Hopefully, we keep that number of misses as low as possible. Number two, unfortunately, we can't change rule one. There's going to be misses all the time. Hopefully not all the time, but a few times. And finally, rule number three, the aorta will mess you up. These rules came from Dr. Cliff Reed. He's an emergency medicine physician. He's actually one of the originators of what we call FOAMed, free open access medical education, which is something that I really enjoy keeping up to speed nationally, internationally with leaders in emergency medicine and emergency nursing about free open access medical information. And so obviously, Dr. Reed didn't say mess you up. I'll leave it to your imagination as to the word he actually used. And just finally, one more quote, Sir William Osler, basically the god of physical examination medicine. There is no disease that is more conducive to clinical humility than aneurysm of the aorta. So again, it was recognized 100 years ago that the aorta can have a problem, and we will often misdiagnose it. So we're going to just start off today with this case. Again, this is a real case my partners and I had a few years ago in our emergency department. This was a 38-year-old female. She's about 36 weeks pregnant. She's gravidas 6, para 5, no prior miscarriages or abortions. She had had a sudden onset of chest pain that radiated up towards her neck and jaw, rated as a 10 out of 10 almost instantly. She had just had some dinner. She was doing dishes. She had some nausea without vomiting. She got sweaty. And if you listen to anything from Dr. Amal Matu, sweating is always a bad thing. Something bad is going to happen. So she and her husband called EMS. EMS arrives. They kind of lived in a rural area, so it took a few minutes for them to get there. They did all the standard stuff for chest pain. IV, oxygen monitor. Vital signs were pretty good. Blood pressure was great. Heart rate, she was not tachycardic. A little fast on the respirations, but she's hurting. And she's oxygenating well, 98% sats on room air. And this was back before we started kind of withholding oxygen with people with normal saturation. So everybody used to get oxygen, not so much anymore. They did an EKG. It showed a sinus rhythm without any ischemic changes. They gave her some pain medicine. They gave her some nausea medicine. Transported her to my emergency department with no really significant change in her condition on arrival. In the emergency department, she's assessed immediately. She's still having ongoing pain, still about a 10 out of 10. She again describes now a sudden abdominal pain radiating up into her back and neck and chest. And she states, felt like my prior pancreatitis. So of course, we're kind of focusing on that. This is a young, otherwise healthy woman with a history of pancreatitis. And she says, this pain feels just like it. She reports that there's no problems with her current pregnancy. There's no problems with her prior pregnancies, like pregnancy-induced hypertension or eclampsia or preeclampsia. And she's still very uncomfortable and restless, and she's having trouble sitting still because she's just so uncomfortable and in pain. Past history included gallstone pancreatitis, some kind of autoimmune disease like rheumatoid, but really didn't know what it was, and it was still kind of being worked up at the time of her presentation. But really no significant known cardiopulmonary, cardiovascular, or kind of peripheral vascular disease. In the ER, blood pressure is a little bit higher. So, you're thinking, is this, a preeclamptic presentation? Heart rate still was good. Respirations were improved. She was afebrile, and she's satting 100% on room air. So we take her off the oxygen, and she's still oxygenating well. We utilize the services of our on-site OB nurses, and they placed her on fetal monitoring. There were no contractions detected. Fetal heart rate was good at about 150. It's still very painful, still very nausea. We continued treatment. Here's her actual EKG, a sinus rhythm, no real ischemic changes at all, normal ST segments, normal T waves. The only thing to mention is she does have a slight leftward axis. She's got a normal upright QRS in lead 1, but a negative QRS in lead AVF, so a slight leftward axis, which with her stage of pregnancy, kind of in the mid to late 3rd trimester, there is going to be some shifting of the heart, so the left axis deviation is not unheard of in that stage of pregnancy. So really an unremarkable and unimpressive EKG. We get a portable chest x-ray, and we do think that maybe the heart shadow is a little bit big, but this is a portable chest x-ray in the AP presentation, and so the heart size is enhanced in that position, in the AP position, as opposed to the standard PA that they would get if they went over to the x-ray department. So even though the heart shadow does look generous, understand that's being pushed up from the advanced pregnancy, up pushing up with the diaphragm. It's kind of shifting the heart, and again, the technique does kind of enhance that heart shadow size. So again, we're not thinking anything bad here either. So a pretty unremarkable chest x-ray. We did the routine lab work, and again, nothing really horrible or surprising here. She's got a slight elevated white count, but again, that's not uncommon in pregnancy to have a slight leukocytosis. She's slightly anemic at 10.8, but again, there's that known anemia of pregnancy from increased plasma. Her platelets are normal, so we're thinking it's less likely to be HELP syndrome, hemolysis, elevated liver enzymes, low platelets. Her basic panel's normal. Her alkaline phosphatase was a little bit high at 129, but the rest of her liver function tests were normal, and her lipase was normal, and her urine was normal. There was no protein in her urine to, again, suggest preeclampsia as a potential problem here. In the emergency department, continue to have stable vital signs. Blood pressure kind of stayed around the 130 to 140 range systolic. Continue to have, though, severe intractable pain despite multiple doses of pain and nausea medicine. Finally, use shared decision-making to go ahead and get a CT scan of her chest and abdomen. She's at 36 weeks gestation. Risk to the fetus at the time is minimal for the radiation exposure as compared to if she'd been like in the early 1st trimester. So she agreed to go ahead and get scanned. And at this point, we're thinking, is it bad heartburn? Or is it maybe aortic dissection or something wrong with the aorta or something else vascular going on? And so here's her CAT scan, and I'm going to apologize up front here. I was hoping that I would be able to have a visible arrow for you on the screen as I scrolled around, but I was told later that I don't have that. But again, this is a axial slice starting at towards the top of the lung apex. So she's laying on her back, her head is away from us, and to the left of your screen is the right side of her body, to the right side of your screen is the left side of her body. And as we kind of scroll down, we start coming through the aortic arch, and you see that little fuzzy line, that dark line through that curvaceous column of contrast. That's her aorta, and that is an intimal flap in the aorta. That is her aortic dissection. And as we continue to scroll down, towards the left side of your screen is going to be her ascending aorta coming down to the aortic valve. And we still see that nice fine line going backwards towards the ascending aorta and aortic root, and then down the thoracic aorta into the chest. And as we continue down, we see that dissection flap continues towards the diaphragm. So she has an extensive dissection from the ascending aorta over the arch and down the descending thoracic aorta. And then there's the baby. A couple quick pictures there. All right, so now we've got a problem. We've got a young, otherwise healthy lady who's in her 3rd trimester of pregnancy who's experiencing an acute aortic dissection. So what is aortic dissection? Simply a separation of layers within the aortic wall. Typically it's the intima, the most inner lining, separating from the muscular media and the outer adventitial layer. Mortality is very high despite advances in making the diagnosis and therapeutic interventions. So again, we can make the diagnosis, we still have to fix the problem. There's some classifications that are typically used to describe aortic dissections. There's a DeBakey criteria. DeBakey 1 and 2 is when there's any involvement whatsoever of the ascending aorta before the arch. DeBakey type 1 is ascending and descending thoracic aorta. DeBakey type 2 is isolated to the ascending aorta prior to the takeoff of the left subclavian artery. DeBakey 3 is isolated to the descending thoracic aorta. The other criteria is called the Stanford criteria. There's Stanford A, which again is any involvement of the proximal aorta, whether there's descending involvement as well. And then Stanford B is just isolated again to the distal or descending thoracic aorta. And Shalonda, I will have Cheryl Randolph answer that question about the slides being available, but I think this was going to be recorded. So the dissection causes that separation of those layers of the aorta, and so you get a true lumen where the normal blood flow is occurring, and on imaging, like a CAT scan, is going to have a round or slightly oval shape to it. Rarely has clot involved. The false lumen has more of a crescent shape to it, has very poor blood flow through that false lumen, and a thrombus is very, very common to occur there, so it starts to clot off as it evolves. Several etiologies. This can be due to congenital problems, some baseline health issues. It can be acquired through several health conditions. It can be iatrogenic. And a final is what's called cystic medial necrosis. And I again apologize, here's my hopefully only busy slide. This is a near complete list of the congenital causes of aortic dissection. A lot of these are typically connective tissue or some kind of genetic abnormalities, things like Marfan syndrome, history of family dissections, polycystic kidney disease, Turner syndrome, Noonan syndrome, osteogenesis imperfecta is a risk factor. Patients have a congenital bicuspid aortic valve or who had a prior coarctation are all at high risk for this. Things that can lead to acquired risk for dissection is long-standing, poorly treated arterial high blood pressure. Pregnancy is a risk factor, particularly if there is another pre-existing condition, such as Marfan syndrome. It's reported that about 50% of dissections that occur in women less than 40 years of age are associated with an active pregnancy, and most of these occur during the third trimester or early postpartum. There can also be syphilitic aortitis, and then chest trauma and cocaine use can all contribute from an acquired standpoint. Iatrogenic causes, things that we do as healthcare providers that could cause this. Patients who have undergone aortic and mitral valve replacement, patients who've had CABG surgery, and any time we're doing any kind of percutaneous catheter placement. So someone who's just gone for a heart cath could be at risk for developing an aortic dissection from trauma from that catheter. Cystic medial necrosis is that final risk factor. It's just some degenerative change within the collagen, elastin, and smooth muscle of the aorta. And so necrosis occurs, that inner wall becomes weak and is at risk for tearing and dissection. And so the dissection occurs. So what are the numbers? In the United States, it's fairly uncommon. There are about 5 to 30 cases per 1 million people per year. And it equates to about 1 per 10,000 patients who are admitted to the hospital. It does occur more frequently in blacks, more than whites, and more than those of Asian descent. There's a male to female ratio of about 2 to 3 men for every 1 woman who suffers dissection. Most occur at the age of 40 to 70 years of age. Patients with Marfan present typically earlier in life, so around age 30 to 40, they can present with their dissection. I actually had a friend in high school who had Marfan syndrome, and at the age of 17, he collapsed while mowing the lawn and from his ruptured dissected aorta, so it can occur even as a teenager or even very younger. So signs and symptoms. The classic is a sudden severe chest pain that's often described as a tearing or ripping sensation. Can be anterior chest pain radiating to the neck or to the jaw. Again, that tearing or ripping midscapular pain. About 10% of patients, give or take, can experience no pain, but they do present with other deficits like a pulse deficit or a neurological deficit. They can have syncope, they can have neurosymptoms such as hemiparesis, hemiplegia, hemianesthesia, or may just present with an altered mental status with or without chest pain. Other signs and symptoms, numbness and tingling, or pain or weakness in the extremities, depending upon the direction of the dissection. Does it dissect into the upper arm arteries, into the leg arteries? Horner syndrome, which is unilateral ptosis, meiosis, or anhidrosis, indicating some carotid involvement from the aortic dissection. They can be short of breath, they can be coughing up blood, they can have trouble with speaking and swallowing, they can have abdominal pain or flank pain, and they may have this premonition of death. They have that sensation of impending doom that's often described with patients with chest pain and other cardiac problems. So some high-risk clinical features. This is a slide from Academic Emergency Medicine. This was a case control study of patients greater than 18 years who had acute atraumatic truncal pain. And the best descriptors, or the best things that put them at high risk for suspicious for dissection, was again the description of pain as being tearing or ripping. If there was a pulse deficit, a great pulse in the right arm, no pulse in the left, or great upper extremity pulses but poor lower extremity pulses. Hypotension, if there's a new murmur, especially a new systolic murmur, which could indicate aortic root and aortic valve involvement of the dissection. A widened mediastinum or an absent aortic notch on a plain chest x-ray. And again, that abrupt onset of pain, an almost instantaneous pain that it was maximal 10 out of 10 pain. So there's some key concepts of thoracic aortic dissection. These are called the key things to kind of think about for where you increase your suspicion. We call these the 5 pain pearls, the concepts of either chest pain plus 1 or 1 plus chest pain, physical exam finding that are pearls, initial test pearls and pitfalls. Then finally, what medicines do we give to stabilize these patients, and in what order do we give them? So pain pearl number 1, ask these 3 questions in patients with truncal pain, especially chest or back pain. What's the quality? How would you describe your pain? Often described as sharp, but the highest likelihood ratio for dissection is someone who describes unsolicited a tearing pain either in their chest or between their shoulder blades. Second question is, have them describe how intense the pain was at the onset of symptoms. Again, highest likelihood risk factor is maximal intensity at the onset of symptoms. Then finally, does the pain radiate? And again, think about the pathway of the aorta. It starts in the middle of the chest, it goes up towards the neck as it arches over, and then down the back. So does the pain radiate upward, up into the neck or jaw? Does it go down into the arms? Does it go down the body below the diaphragm into the abdomen? A study showed that if you asked all 3 of these questions, the diagnosis of dissection was suspected in 91% of people who eventually had it. But if you only ask 1 or 2 of those questions, that suspicion dropped to only 49%. So those 3 questions, the quality of the pain, intensity at onset, and does the pain radiate anywhere? And think again about that pathway of the aorta for your pain distribution. Pain pearl number 2. Think of dissection as the subarachnoid hemorrhage of the trunk. You've had those patients with subarachnoid hemorrhage. What's the classic thing? Sudden onset, severe, worst headache of their life. Dissection's no different. Sudden, severe symptoms of sudden, severe chest pain, sudden, severe back pain. It's that rapid, immediate, abrupt onset that makes us think more about dissection. Pain pearl number 3. Is it severe colicky chest pain that kind of waxes and wanes? But when it's bad, it requires opioid therapy to treat the pain. So if you got a bad chest pain and it's requiring opioids, fentanyl, morphine, Dilaudid, think about dissection. Put it on your radar. Doesn't mean they have it. Could be MI, could be PE, but don't discount dissection yet. Fourth pain pearl, migrating pain. Pain above and below the diaphragm. Again, what direction does the aorta go? Up off the heart, up towards the neck, arching back, and then down the spine. So pain above and below the diaphragm makes us think about the aorta. Severe pain that progresses and moves. It started in the chest, but now it's moving downwards towards the lower chest and down into the abdomen or down into the arm. Again, as that dissection expands. Pain pearl number 5, the pain can be intermittent. You can have severe migrating pain and then it resolves. Then as the dissection starts to tear further, pain returns. So that intermittent pain that is severe and radiating, again, heightens our suspicion for dissection. Unfortunately, there can be painless aortic dissection. The International Registry of Aortic Dissection reported painless aortic dissection rate of about 5%. A few years ago, there was a study out of Japan that showed that there was about 17% of dissection patients had no pain whatsoever. But what they presented with was an abrupt onset of level of consciousness from impaired perfusion from the aorta to the brain, any kind of focal neurological deficit, or the presence of cardiac tamponade without recent trauma or other line conditions. Some more pearls. The concept of what's called chest pain plus 1 or 1 plus chest pain. When we think about big red or the aorta, when it dissects, it starts to devascularize tissue that it is supporting. So someone presents with sudden onset of severe chest pain, but is now also having stroke symptoms as that dissection goes up the carotid arteries to the brain. Is there acute onset of chest pain or mid-back pain with paralysis of an extremity or extremity of the lower, or paralysis of the lower body? Is there sudden onset of chest pain and a new hoarseness of voice? That dissection is compressing against the recurrent laryngeal nerve and changing their voice. And then chest pain plus limb ischemia. Again, an arm or a leg that has a poor pulse or an absent pulse or a significant blood pressure difference from the right arm to the left arm or the arms to the leg. It's also helpful to think backwards in time. Someone comes in, looks like they're having a stroke, or they've got a pulseless foot or a pulseless leg. Ask them, were you having any chest pain before these other symptoms developed that's now resolved? So kind of think backwards with these stroke patients, with these paralyzed patients. That's not trauma. With these patients with a pulse deficit. Did you have any chest pain prior to this? As a clue that it could be a dissection as the cause. So there's also some physical exam clues, some physical exam pearls for aortic dissection. We need to look, listen, and feel our patient. If they're 40 years or younger, ask about or look for signs of Marfan syndrome. Patient doesn't want to know they have it. So you need to look at the patient, look for these signs, arachnodactyly. I'll show some pictures here in a moment. Pectus carinatum or pectus excavatum, or long, thin, lanky limbs. If there's a aortic regurgitation that is new, has a very high likelihood ratio that this is a dissection. If there's a new pulse deficit, again, a higher likelihood ratio that this is a dissection causing their symptoms. So here's an example of pectus carinatum, that very prominent outward appearance of the sternum. And then the opposite of this is pectus excavatum, so that caved in, sunken chest. It's not always this prominent or this overt, but again, just kind of shows you the extremes of those two conditions. Some hand things you can do, you're probably going to be doing some of this as I describe them. There's the wrist sign. If the patient can encircle their wrist and the thumb and little finger overlap, that's a clue physically that they may have Marfan syndrome. Arachnodactyly is just very long, elongated fingers. And the thumb sign is you have the patient fold their four fingers over their thumb across their palm. And if the tip of the thumb sticks out past the little finger, again, that's kind of consistent with the long fingers, the long thumb. And again, it's another physical sign that they could be suffering from Marfan syndrome. And I'm sure all you're out there doing this right now as we're talking about it. Something else we can look for is this high arched palate and crowded teeth. Can also be a physical clue that the patient does have underlying Marfan's disorder. Some famous Marfan patients throughout history, either known or suspected. Abraham Lincoln, Julius Caesar, Osama bin Laden, and King Tut. Although some recent evidence that I just read about a week ago is that it's no longer thought that Lincoln suffered from Marfan's, although he maybe had some Marfan-like physical characteristics. They don't think from testing some relative DNA that he actually truly had Marfan syndrome. So there's a little bit of history there for you history buffs. Are there any diagnostic tests, again, short of doing a CAT scan, that could, again, lead us towards that diagnosis? So things we commonly do in the emergency department, we get a chest x-ray, we get lab work, we can do point of care ultrasound, or what we often call POCUS. For chest x-ray, about 1/3 of these patients will have a normal chest x-ray. There are some clinical clues on a chest x-ray, however. First, try and compare to an old chest x-ray if you have it available. Has there been an interval change in the size of the mediastinum or the shape of the aortic arch or the aortic notch? And then second, look for more than just the wide mediastinum. Is there loss of the aortic knob? And then what's called the calcium sign. So here's an example of a couple chest x-rays. On the left is a normal chest x-ray. That circle shows the aortic arch and aortic knob, and there's that little concavity called the aortic pulmonary window that should be normally present. And on the right-hand side, we see a patient who's lost that concavity, and there's some blurring or blunting of that aortic pulmonary window. So that's a suspicious sign for dissection. It's not diagnostic. Again, it just makes us more suspicious in the appropriate clinical setting. Again, kind of going back, this is our patient's chest x-ray. Again, the technique is different. This is an AP chest, so it does kind of enhance the heart size and heart shadow. But with our hindsight being 2020, you might say, yeah, there's kind of that blunting of that aortic knob, that loss of that aortic pulmonary window. Maybe we could have thought of this a little bit sooner based on the chest x-ray. But as always, hindsight's 2020. The calcium sign, this is a very prominent, big, dilated aortic arch knob. And if we kind of overlay it, that yellow line is the true inner lining of the aorta, and that red line is the outer adventitia wall. If there's more than 5 millimeters between those two lines of calcium, then it's highly suspicious for a dissection. Can we use any blood tests? About 25% of patients with dissection will have an elevated troponin. And then D-dimer, again, jury is still kind of out, but there was a recent study 3 years ago in 2017 called the ADVISED trial, aortic dissection detection risk score plus D-dimer in suspected aortic dissection. And basically what it did was we looked at a detection score. Did they have any predisposing conditions that put them at risk for dissection, such as Marfan's, family history of aortic disease, known aortic valve disease, recent manipulation, the pain features, and any physical exam findings, such as a pulse deficit, a focal neurodeficit, a new murmur with the pain, or they presented hypotensive or in shock. And if any positive in any column, you get 1 point. So then they had this algorithm. Patient presents with chest pain, belly pain, back pain. They may have syncope. They may have perfusion deficit. That kind of goes into your pretest probability. You go through those clinical clues between pre-existing conditions and signs and symptoms. If they had an aortic detection score of greater than 1, you moved right to the CT angiogram. If their score was less than or equal to 1, you got a D-dimer. If the D-dimer was normal, you stopped that pathway. If the D-dimer was elevated, you went to CT angiography. And this algorithm in that one study missed 1 out of 300 aortic dissections. So about 0.3% miss rate, which is a lot better than our current way we addressed chest pain rule out in my patients. We use the heart score to kind of risk stratify those patients who come in with chest pain. If they have a heart score of less than 4, we can discharge those patients home, and that's about a 1 to 2% miss rate. So this score for dissection has a better detection value than the heart score does for coronary artery disease. So it's a lower level of risk acceptance in this. We can use point of care ultrasound to, again, facilitate detection. One way I like to describe this is that aortic dissection is the retinal detachment of the torso on point of care ultrasound. The reason I say that is on ultrasound, the intimal flap in the aorta looks like a retinal detachment flap on ocular ultrasound. So here's just a diagram. The red blood is showing extravasation into that false lumen, but also back into the pericardial sac and causing a pericardial fusion and potentially a pericardial tamponade. So on the left-hand side of your screen is a ocular ultrasound of someone with a retinal detachment. So you see that nice little flap in that nice round, dark orbit. On the right is an aortic dissection. So that nice dark oval is the aorta, and that white line is that intimal flap. So that flap is the clue to the presence of dissection. Ultrasound also of the heart. We see the left ventricle there with the myocardium surrounding, and then that black line highlighted by the arrows is the pericardial fusion. So that's blood within the pericardial space. And so that patient, again, has more clinical clues, more diagnostic clues for dissection being present. All right, we've made our diagnosis. We've got someone who came in with severe onset of severe chest pain or back pain. It radiates up into the neck and down into the abdomen following that course of the aorta. They might have a pulse deficit. They might have a neuro deficit. We've gotten our diagnostic studies. We've gotten their CT angiogram. We have the confirmation that they do have a thoracic aortic dissection. Now, if any patient has involvement of the proximal ascending aorta, they almost always require surgery. The only reason they would not, if they had other significant comorbidities that made surgery a horrible risk to begin with, or if their life expectancy to begin with was poor. But in the general population, any involvement of the proximal ascending aorta, so that Stanford A, that DeBakey 1 or 2, they need at least surgical evaluation. If it's isolated to descending thoracic, then medical management may be all they need unless their condition worsens. So in the emergency department, though, we need to stabilize them. We want to try and get their pain under control, get their heart rate under control, and finally get their blood pressure under control, and typically in that order. Our first step is to control their pain, because what happens when we're having pain, our sympathetic nervous system kicks in, it increases our heart rate, it increases our blood pressure, which worsens the dissection. So pain control, I typically use fentanyl boluses or infusion. You can use morphine, you can use hydromorphone, it's whatever your drug du jour is, but getting their pain under control. Second step, and again, these are often happening concurrently or concomitantly, we want to get good heart rate control to a heart rate of about 60 beats per minute. Faster heart rates put more of a shear force or a tearing force on the aorta. It's the calculation of change in pressure over change in time. So if we can get that heart rate down, that's going to reduce shear stress, tearing forces on the aorta and hopefully limit any further dissection. So heart rate control to a heart rate of about 60 beats per minute, lower, maybe 50 beats per minute if they can tolerate it. And again, we typically use a short-acting beta blocker like esmolol because we can get it rapidly on and we can titrate it to a heart rate effect. Finally, if their blood pressure is still elevated after heart rate and pain control, we want to get their blood pressure down to about 110. And you can use either nitroprusside, which we rarely use anymore. We typically go to something like nicardipine. And again, titrating to get blood pressure down to about 110 systolic. So again, pain control, heart rate control to about 60, maybe 50 if they can tolerate it, and blood pressure control to a systolic of 110 beats per minute. So back to the case, our young lady, our young lady with pregnancy, 36 weeks pregnant. She has a type A dissection using the Stanford criteria because there's proximal involvement. She's actually a DeBakey 1 because she does have proximal ascending as well as descending thoracic aorta involvement. We got her pain under control with fentanyl bolus and infusion. We immediately started an esmolol infusion. And fortunately, did not require any further blood pressure control. The pain control and the heart rate control got her blood pressure down to about 100 systolic, and she was doing very stable with that. So again, we've got this young lady in our very small community emergency department. We obviously don't have vascular surgery services at my little place. So she needs vascular evaluation, vascular intervention, high-risk OB, and potentially a neonatal ICU, again, all of which are not at my facility. So we simultaneously made consultation with the thoracic vascular surgeon and OB doc at the level 1 center about a half an hour from our facility. And she was emergently transported by ground ambulance to that facility. Once on arrival there, she was taken almost immediately to the operating room. She, under general anesthesia, underwent a stat C-section and delivery of a healthy child. She then went to open repair of her dissection with an aortic graft, arch graft, and both mom and baby did very, very well. Both of them were out of the hospital in less than a week, and we've seen them in follow-up a couple times in the ER for other issues, and both mom and baby are doing very, very well now several years later. Excuse me. So some take-home points as we round up here. 3 important questions. Remember those pain pearls. What's the quality of the pain? Highest likelihood ratio for that tearing, but also sharp. What was the intensity at the onset of symptoms? Again, that sudden, severe, maximal intensity of discomfort. And then does the pain radiate? Thinking about that distribution, that pathway of the aorta, up towards the neck and jaw, down the chest, and into the abdomen. We want to look for those signs of Marfan syndrome. We want to listen for a new aortic murmur. We want to feel for a pulse deficit in the extremities. So we're going to look, we're going to listen, we're going to feel. Again, think not only about chest pain +1, those chest pain with other new symptoms like stroke, pulse deficit, altered level of consciousness, but also the patient presenting with stroke, did they have chest pain prior? So that 1 plus chest pain. Think about those chest x-ray findings, that loss of aortic knob, that wide mediastinum, and that calcium sign. Using point-of-care ultrasound or POCUS to look for that intimal flap of the aorta, to look for that pericardial effusion. Don't be misled by a positive troponin. It may not be an MI, it may be a dissection. Again, there may be a use for a D-dimer using that detection pathway. And again, how do we treat? Get their pain under control, get their heart rate under control to about 60, and then blood pressure down to about 110 systolic to stabilize that aorta and hopefully prevent any further dissection. So we all feel great when that patient with an aortic dissection presents just like the exam board question. They've read the book, and they present with all the classic signs or symptoms. Makes our job easy. But our job is never easy. These patients don't always read that textbook. They come in with perhaps less exciting symptoms, may just be altered mental status, may just be new stroke symptoms. It could still be dissection. Looking at a couple questions. Is the D-dimer always high in pregnancy? It can be. That does make, if you think about our pregnant patient with a PE, we do know that D-dimer is typically elevated in second and third trimester pregnancy. So that could have been confounding in this case if we had used that test. The algorithm we described just a few slides ago did not count pregnant patients in that evaluation. So again, the D-dimer typically is elevated in pregnancy, so that kind of confounds the diagnosis. And then Linnell asked about the blood pressure. Is the MEP normal in late pregnancy of 100? I don't recall specifically now if we got blood pressures in the arms. We just were more concerned about her refractory pain, and we were thinking about dissection as a possible risk and just went to CT. But I don't recall that she had any deficits. But again, it's been about 3 or 4 years ago. So Linnell, I'm sorry, I don't have that exact answer for you. All right, so remember I said there was going to be a quiz at the end. We just want to chime in chat. What's rule number 1 of aortic dissection? Remember our little slides at the very beginning. There you go. You will not diagnose every aortic dissection. You're going to miss some. And again, we try to keep those numbers low by having a heightened suspicion and awareness for this disease process. What's rule number 2? Exactly. You cannot change rule number 1. You're still going to miss some of these. And finally, what's rule number 3? The aorta will mess, or your own vernacular, mess you up. And again, thanks to Dr. Cliff Reed of the Foamed World for that nice little rule. So I want to thank everyone for attending today. You're all wonderful ER nurses. You are very, very awesome. And my favorite, there's no kill switch on us ER nurses being awesome. So again, I do thank everybody for showing up today. This again is my first really live webinar. So I'm sorry if my focus was going all over the place as I looked at the chat, looked at the screen, and tried to keep up with everything. If you do want to follow along with me, I did see some familiar names on the chat room today, and I'm glad everybody came. I am on Facebook, Andrew Bowman, and I'm on Twitter as @AndrewACNP1. As I described earlier, I really enjoy Foamed, free open access medical education, as well as Phoned, free open access nursing education. As my followers know, I put out about 5 to 15 things a day of late breaking information from the emergency medicine, emergency nursing, critical care world. I just kind of share that information freely. So happy to jump on board. I will not spam you with anything if you follow along with me. I'm going to hang out here for a few minutes if there's any further questions. And again, if you think of something later, my email is andrewj.bowman@gmail.com. Or again, you can find me on Facebook or Twitter, and we're all happy. And Cheryl, I wore the bow tie just for you today. Hi, Scott. Hope you're doing well, my friend. Okay. Since I don't see any more questions coming up here, I'm going to go ahead and end that. Thank you again, everybody, for attending. Thank you for making this as painless as possible, Cheryl and Alice. I appreciate everybody's help. And again, reach out to me later if you have questions. Lori, that's in the works. So we're working on that, my friend. All right. Everybody have a good day. I'll hopefully see you all again soon. Thank you, everybody. Have a good day.